this. First of all, this guy's, of course, this guy's in the way, but hey, if you can't see something, then first of all, I like to say welcome to you all. Welcome back again, I must say, here. We're talking about, tonight we're talking especially about the joint therapy in relation to the late consequences after an inversion trauma and distorted ankle. And what I like to do is to introduce a kind of joint therapy which you can use to optimize the arthrogenic function with manual mobilization techniques, which is effective, swift, pain-free, and certainly safe for your patient and also for the therapist to conduct. Actually, talking about mobilization, when you have to deal with a restricted movement, a restricted range of motion, which can be or even cannot be painful, so it doesn't depend on the existence of pain, but if you have to deal with a restricted motion and you want to mobilize it, and you use active or passive movements for mobilization purposes, then you're very, very likely to get tissue damage. And actually, one of the worst examples that I know is, nowadays it's not all that often, but one of the worst examples I know is having a frozen shoulder, in which sometimes orthopedic surgeon comes with the idea, well, let me put you under narcosis. And then we're going to try and move this shoulder passively to a full range of motion. Or, if you want an active example, the active example is, for instance, after an operation where there's a restricted shoulder function, and people get exercises like, well, go to the wall and climb up with your fingers towards the wall as high as possible, and then at the best go a little bit further than that. That's trying to mobilize something, a joint with active or even passive movement. You're very likely to get tissue damage. And actually, that's not really the point in treatment, in treating patients, I guess. I think you want to let your patient to be as sound and heal as possible. If you're mobilizing that with specific techniques, then you're far more safe and you will not get any tissue damage. Tonight, for this occasion, I wanted to present to you a case history. And the case history in this presentation is about a 7-year-old girl. And this 7-year-old girl had an ankle trauma about 4 years ago. And after her ankle trauma, she had pain and restricted function in dorsal flexion, was painful, and it has been ever since her trauma. So that's for over 4 years now. And you know what? The little girl's dream was to jump up and down, to bounce up and down on a trampoline. But she couldn't, because of the restricted function. There was too little dorsal flexion, and she had pain when jumping or when running around and things like that. 7-year-old. Interventions done in these 4 years? Well, actually, everything you can think of. Physical therapist, pediatrist, orthopedist, it was put in cast, everything you can think of was done. Electrotherapy, perhaps, but a lot. And nothing could give actually the solution. So the problem remained. And actually, when you're talking about a 7-year-old girl with long-lasting problems after an ankle trauma, after such an inversion trauma, you can ask yourself, is that a soft tissue damage? Because actually we all have tend to see inversion trauma actually as soft tissue damage. And that is, of course it's possible, but after 4 years in a 7-year-old, actually, especially with such a young kid, you would have thought that in 4 years of time, the soft tissue would have healed. Certainly in such a young kid. So that's put down there with a question mark. Is it really soft tissue damage? Or could it possibly have something to do with the function of joints? Well, let's talk about that one. And first of all, and I must say that I make big leaps in this lecture, but the first thing I want to emphasize, and which is important to solve actually this case, is to know something about the mechanics in the foot and the ankle. And actually lower leg, ankle and foot, well, that's very much closed motion system, and there are no isolated joint movements in what joint whatsoever that takes part of the system of lower leg, ankle and foot. There's always multiple joints involved in a proper functional movement, always. And especially if you want to come to full range of motion, you need more joints, and more joints are involved. If you look at the mechanics of inversion and eversion, then it's actually rather clear. Not only is inversion and eversion movement which takes place in multiple directions, but it also takes place in multiple joints. And inversion is a combination of supination, adduction and plantar flexion. Eversion is a combination of pronation, abduction and dorsal flexion. And sometimes you come across different definitions where they say that pronation is a combination of eversion, abduction and dorsal flexion. Know about that? But okay, let's define inversion and eversion for now, just like this. Such a combination. When you look at inversion and eversion, and you look at inversion non-weight bearing, then you see that multiple joints are involved. First of all, there's a movement of the calcaneus compared to the talus. And I have this guy here, which is giving not a very vivid example, but you can see some joints in him. First of all, the calcaneus moves compared to the talus joint, and it moves to adduction, supination, and a little bit of plantar flexion. Apart from that, you've also a movement between the navicular and the cuboid. And there's also a similar movement is taking place, where cuboid and navicular compared to the calcaneus comes also in the same direction. So adduction, supination and a bit plantar flexion. Apart from that, you have this complex, this whole of talus and navicular, talus bone and navicular bone, which will stay rather close together. But there's a slight movement, a slight gliding compared to the navicular bone. So actually, and here you have a drawn example of the foot. Actually, in version non-weight bearing, there are multiple joints involved. Between talus and calcaneus, you have to deal with calcaneus and gratuit, and you also have to deal with the talus and the navicular bone. And if you come into an inversion movement, and we are still talking about a non-weight bearing movement, then these movements, this inversion movement, should take place at the same time. If in this chain of in this movement chain, if you would fixate one of the joints and you invert the second joint, then you will luxate the third joint. And actually, it's not even interesting which of the joints you call 1, 2, or 3. That's so happens. That's inversion non-weight bearing. And of course, most of the inversion traumas are weight bearing traumas. But in weight bearing situation, something similar happens. And in weight bearing situation, you also have multiple joints that are involved, but because you are weight bearing, the calcaneus can't move towards the talus. But then again, which can move is the joint between talus and cruris. So then the lower leg and the talus move compared to the calcaneus. And the cruris is also involved. Still, that stays the same. If you fixate one of the joints involved and you invert the second joint involved, then you will luxate the third joint involved. Can be a little problem. So that principle stays actually the same. Now, we talked about the inversion and the movement of inversion. Let's make let's jump towards the next highlight. And the next highlight is think about the mechanics which are taking place in a proper dorsal flexion function. And in proper dorsal flexion function, if you want to have full range of motion, in the last part of this dorsal flexion, this wedge-shaped talus is pushing into the fork which is made between tibia and fibula bone. And to get into this last 5 degrees of dorsal flexion, it is absolutely necessary that the fibula slides a little bit to the side. And actually the fibula bone in height of the syndesmosis slides a little bit to the lateral and the proximal side. If that fibula bone doesn't slide to the lateral and proximal side, then this end position of dorsiflexion is simply not possible. So that will inhibit the dorsiflexion. At the same time, you all know that you need this proper dorsal flexion function when you want to have a proper to run properly or to jump properly and to develop enough strength, enough force to jump and to run and so on. So the movement of this fibula is not that much, it's actually rather small, but it's crucial. When it is not taking place, then you will not have a full range of motion. If that movement takes place on the distal side, then well, your fibula is one straight bone. It is not very flexible, as bones usually aren't. So if it moves on the distal side, then it has to move on the proximal side as well. And when it moves on the distal side to a little bit to the lateral side and the proximal side, then it must move, inevitably, must move on the proximal side as well, just in the opposite direction, so a little bit to the medial and the distal side. Actually, that's what you see with this long-lasting complaints after an infusion trauma. These fibula bones are very often involved, not always, because the problem can occur in the other joints involved with inversion as well. But the fibula joints are very often involved, and actually I must say as much as often overlooked. It's very often an overlooked problem. Okay, from here I'm going to take another jump to emphasize the third problem which you can come across. And before I'm talking about the first problem you may come across, let's focus on the arches of the foot. Mostly the longitudinal arch. And actually, this longitudinal arch is mostly formed by the architecture of the bones. But at the same time, it keeps its shape because of the plantar aponeurosis. And this plantar aponeurosis is attached on the calcaneus, a bit on the medial side, and more to the distal part, it's attached to the proximal phalanx of each toe. This plantar aponeurosis consists of collagen fibers, and these collagen fibers are not very elastic. Actually, they don't stretch. But if you walk during a normal walking pattern, during the push-off phase, your toes will come into dorsal flexion. And if a dorsal flexion occurs in entity joints, that would mean that the distance between calcaneus and the proximal side of the first phalanx is lengthened. But actually, this plantar aponeurosis prohibits that. It can't lengthen. So when the toes come in dorsal flexion, actually the height of the foot arch increases. That will give you a stronger leverage, so you can develop more force in jumping, running, walking, and so on. It's very beneficial. But to increase actually the height of the foot arch, then a plantar flexion in the tarsal joint is absolutely necessary. When the tarsal joint doesn't come in a plantar flexion position, well, then this movement is not very likely to occur either. And then you also have a problem in the push-off phase during walking, jumping, and so on. So, actually there we have the third culprit. To repeat myself, there can be more causes, but these long-lasting problems after an ankle trauma, after an inversion trauma, after a distorted ankle, often caused by joints, and the main culprits are first the fibula in height of the syndesmosis, second the proximal joint between fibula and tibia, and third the tarsometatarsual joint, which must come into a proper plantarflexion. During joint plane investigation, well, that's an investigation actually of the intra-articular movement. You can find out whether or not these joints are the problem. An examination of the intra-articular movement is something else as an examination of your active or passive moving ability. Then you look at the range of motion, but during a joint plane investigation, you take a closer look in the way the joint partners are moving towards each other. That's what you do during your joint plane investigation. And that's crucial for a proper function, for a proper joint function. If you look at a joint plane, then you always perform that in an MLPP, that is to say, a maximally loose back position, in other words, the position of the joint, the rest position of the joint, where the ligaments and the capsule is less tense and there's a minimum contact between the joint partners. Are there contraindications for your joint plane examination and the therapy which you want to conduct afterwards? Well, yes, there are. Actually, there are several, both absolute and relative. So you always have to watch out for the consequences, for the contraindications. But for now and for this subject, the most important contraindication which I want to mention is pain. Pain during the way you hold the joint, and also pain during conducting your examination. Again, and probably, well, I know for sure you heard about it. You heard me say that earlier, but 0 on the visual analog scale is always your most secure standard, whatever therapy you conduct. And certainly when you do things like this, you stay in the FAS 0. Indications, well, yeah, of course, lots of indications, mostly restricted movements, with or without pain, or, and that's also what you can come across, people who have a full range of motion, but pain during this full range of motion. And that also would be indication for your therapy. At the same time, your examination and your treatment are always conducted pain-free. Of course, telling something about mobilization and things like that, then you also come across the question, why? Why does it function? What's the theory behind it? Why do you have such an, can you have such an effect? And actually, There are a lot of theories about it, and there are some main theories which could explain the effect of your mobilization therapy. And first of all, the first thought is about making a decompression inside of the joint. And that could be partially why it works, why it functions. The second theoretical thought is by mobilizing the joint, you can increase the capsule circulation, and that could also be one of the theoretical explanations. The third one, and probably even more important one, is the thought of neurological rerouting. The theory of neurological rerouting, is it known? Not really. It's that's the painkilling theory, which says, well, on the way, suppose you walk around somewhere and you smash your little toe to a table or something like that. Well, that provides with pain. And this pain signal is leads to your brain on a certain neurological route. And in this neurological route, by giving along these nerves, there are at certain points there are built-in natural body-owned painkiller cells. And the first thing that is happening is that these painkiller cells release their content, which leads to the fact that the stimulus is less. That means that you have a certain that the stimulus as such must be enough strong to end up in your brain where it is being transformed in the sensation of pain. Stimulus as such is not pain, it's being transformed in your brain, and then you're aware of pain. The neurological rerouting effect says that in its way, the way the stimulus takes towards your brain, there are several painkiller cells built in on the route. First thing, what's happening is that the stimulus is less severe, so you won't have pain with a very little stimulus. But then again, suppose you have to deal with a chronic problem somewhere in your foot, for instance, then the route this neurological stimulus takes towards your brain is normally always the same route. But inside this route, the normal physiological painkiller cells are being exhausted because of this constant stimulus, and they haven't time to rebuild themselves. The theory of neurological rerouting is suppose that something like that is happening and you alter the stimulus at the place where pain is being experienced. That means that another neurological path is being used because it's not a stimulus. In this other neurological path, there are still active cells with active pain suppression chemicals in it. So the stimulus will lessen and you will experience less pain. Was that an understandable explanation? Yes, thank you. Thank you. So that's the theory of neurological rerouting, and actually I think that's a theory you use in practice actually rather a lot, because a lot of things you can do within your physiological treatment, within your physiotherapeutic treatment, and also to do probably very likely with this neurological rerouting theory. The fourth theoretical thought which you can talk about in explanation effect of mobilization techniques is actually indeed if you have to deal with a minimal dislocation within the joint and you are able to mobilize it, that the movement will be more physiological afterwards, producing less pain. So that's the fourth theoretical thought. For now, I want actually to build in a practice part, and within this practice part, I would like to show some examples of joint play, actually for a part also passive movement. And I wanted to show both tibiofibular joints, which movement is necessary for a full range of function for your dorsal flexion. And I also wanted to focus on the metatarsal joint, which movement also is crucial in the proper function of your heat in a push-off phase. And those three joints, as I said earlier, are rather often involved within this long-lasting problems after an ankle distortion. Actually, right now, I would like to ask someone to be a self-volunteer in which I can show this kind of joint play as a movement. Wow, you're welcome. Stretch out your first. First thing I wanted to do in the practice part of tonight is the metatarsal joint, or Spheram. And actually, if you probably it doesn't make that much of a difference, I guess, but we can do both feet. And actually, when you're testing a joint play, then you're always perpendicular or parallel to the joint surface. That is something you can do in Spheram as well, but then you take every metatarsal apart. First thing you want to know and want to establish within the tarsal-metatarsal joint is whether or not it has a proper function. And the first thing that happens within your examination is a passive examination of the motion. And by testing the passive possibilities of Spheram, what you can do is use your one hand to fixate the more proximal partner. The other hand is coming from the medial side. The Spheram joint is as close as possible to my both my index and my little finger. The movements I want to test is plantar flexion, and dorsal flexion, and inversion, and an eversion. And actually, I always will talk to you whether or not it's painful, and I want you to say immediately whether or not it is painful. Was it?
In inversion.
Inversion.
Little bit.
Let's see if that has to do with my hands. Right now?
Yeah.
With the left hand or the right hand?
I don't feel very good.
The inside? More on the inside or more on the outside?
Outside.
Okay. So if I'm gonna move.
Yeah.
Okay. that makes me immediately more curious in what's going on around here. So I think in the rest of my examination I would also focus on that part. Now I'm trying to establish whether or not this frank as a whole would be a problem, or that it's more the 4th and the 5th metatarsal. So let me try and even take more care of the way I and now. Okay, if I don't push on your 4th or 5th metatarsal, I can do the inversion. And that leads me to the conclusion that actually it's not a completely strong joint, but somehow, for what reason or another, if you are my patient, I already did a lot of examination and anamnesis and inspection and so on. I already know if there's has been a trauma. Right now I don't know, but surely what he says right now means for me that I also would look more closely to the 4th and the 5th metatarsal. Right now I'm not going to do that, if you excuse me. So in Lee Strike, what you want to do is actually your plantar flexion, dorsiflexion, inversion, eversion movement. Medial hand is fixating, and the lateral hand is moving. In each of the directions, the movement possibility is not that much. It's more or less about 10 degrees which you have. But these 10 degrees you need for proper function, so they're crucial. That's the first joint. The second one I wanted to do is actually the proximal joint of the fibula. And if I'm testing the proximal joint of the fibula, actually, whether you call it a passive movement examination or a joint play examination, won't that be much of a difference, because actually the fibula moves just in one way. It slides a bit to the ventrolateral side and a bit to the dorsal-medial side. So that's always parallel to the joint surface, and that would be the same if you do that with joint play or with a passive movement. To test the joint, what you can do is make about, it's a little bit too much, make about 70 degrees flexion in the knee, like that, more or less. With my medial hand, I try and fixate the tibia, and with my right hand, I try and grab the fibular head, like here. And this is your fibula, and I'm trying to establish if there's actually a movement possible in that direction, ventrolateral direction and medial, ventrolateral and medial dorsal That's the direction. It's the only movement possible. That movement is not very much. It's just a little shift. But the little shift is necessary for a proper function and also for a proper dorsal flexion in the foot. So that was the second proximal fibula joint. Then you also have a distal fibula joint. To test that would be more comfortable, better to perform when you're in a prone position. So if you want to come with belly, and actually we have a very stable table, as stated earlier. If this is in your way, if the table is too much of a stimulus, too hard on him, I can make it a little bit more comfortable by taking a towel or something like that. Here the movement direction is actually the same. The fibula should have a little shift possible to the ventrolateral side and the dorsal medial side. With my left hand I can fixate the tibia, so hold the tibia still, and with my right hand I fetch the fibula and I try if there is indeed a little shift possible to the ventrolateral side and to the dorsal medial side, like that. Well, are we doing no pain?
No.
Except from this problem, which might be in the 5th and 4th metatarsal. I established no other problems in his function. I would like to ask you is to try and perform this, the movement possibilities in this trunk and the shift possibilities of the proximal and the distal fibula joint. That's what you want to grab? Yes. Like this? You don't need to mobilize the muscle as such. This hand should be on the tibia. Yeah, a little bit more on the medial side. This hand grabs the fibula head, but not the muscle. So leave the gastrocnemius alone. This is too far on the dorsal side. Your index finger.
Ah, this one.
Yes.
Here.
Let me so that you can feel. This one fixates tibia. A little bit more flexion. This one grabs the fibula head.
Yeah.
Between thumb and indices, and now I can move it along slightly in that direction, and this is what you should feel. Okay, and you grabbed too much muscle, fixating the joint like that. Your other hand grabs the complete. Yes. And now try it. Yes, and you have to be beneath the joint line. So this hand can be a little bit more on the proximal side. Okay, great. Now grab it. Yes. Can you feel the difference? Yes. now you have a proper, yes, now you have a proper joint test. You're far closer on the joint itself right now, and you are better able to test the actual function. Stay on the medial side.
Oh, I understand.
Because you want to allow the fibula to function.
I understand.
Yes, yes. And you tell us if you're in any pain, huh? Okay. Yes. Like that direction.
Doare? Doare? Da.
Just fetch the yeah. Okay, and it could be a little bit more in a diagonal. Looks great. How does it feel? Is it torturing you? Is it alright? How about this 7-year-old who had for 4 years lasting complaints after a trauma, after an inversion trauma? And actually, this is not a picture of the 7-year-old. I don't have a picture of the 7-year-old on the trampoline. This kid is far younger than that. But actually, after just one treatment, she was able to jump and bounce up and down on the trampoline. It turned out, in her case, that it was actually a problem in height of the syndesmosis, a fibular problem. And actually, you wouldn't think so after 4 years of lasting problems, but actually, in praxis, if you diagnosed it, it's rather easy to solve. And let me tell you, in on a little secret. This syndesmosis problem, not all. Sometimes you need more extended mobilization, but sometimes it is even enough to test the passive function. And after testing the passive function of the fibula within the syndesmosis, you can come across people who say, hey, now I can move my foot pain-free. So actually the solution, if it is that kind of a problem, the solution can be relatively simple. In the case of the little girl, I combined it with medical taping accordingly, and actually in everyday praxis, medical taping and this kind of therapy, this kind of joint therapy, combine very elegantly. So in my practice, I very often use it actually together. The little girl's problem was solved within one treatment, and then she had a full range of motion without any pain. That's actually what you like in your practice. Every treatment you give should give a positive result. The positive result should actually preferably remain, and your goal, the best goal, is a pain-free movement in a full range of motion preferably done, I don't always manage, but it's the best when you can do it in just one treatment. Then your practice results actually that's the moment that I enjoy my profession the most. If I really succeed in one treatment. That's not always so, that's not always the case, but sometimes you come across this kind of problems and you have a very swift, you can have a very, very swift result. This is actually what I wanted to tell tonight within this seminar, or what you call it. Are there any questions? Everything was, yes.
What kind of taping technique did you use?
Yeah, well, in this girl, you can use it, or for this kind of problem, you can use a medical taping technique accordingly. With her, mainly the movement towards the dorsal side, dorsal medial side, was restricted. And what you can do with your tape is use your fascia technique, your jiggle technique. The man has to accept it hip, but solved it. And what you can use is use your jiggle technique, starting with an anchor distally from the joint. Your working strip starts on the distal side of the fibula, and you make your fascia technique, your jiggling technique, actually in the same direction in which you moved the joint with your testing, what you did. So you make the jiggle in that direction, and it comes like a half spiral over the leg. And that would be that would give more or less the same result. Is that clear for you? Okay. I can demonstrate it as well. Any other questions? If there aren't, well then I only can say this was what I wanted to tell you tonight. Thank you very much for your attention. Thank you, Sylvia, for giving me the opportunity. And by having said that, I only can say have a very nice evening.